Good afternoon all. The topic of my paper is Serpiginous-like choroiditis of tubercular origin, the tale of a century-old bacterium. I have no financial disclosures or conflicts of interest. So Mycobacterium tuberculosis is an endemic acid-fast bacilli and it spares no organ, neither the eye. Ocular TB has variable presentation, of which posterior uveitis is the most common. Now, of this, it can either be a serpiginous-like choroiditis or multifocal choroiditis or as a tuberculoma, which essentially presents as a chronic recurrent bilateral disease of the choroid with secondary involvement of the overlying retina. Tubercular serpiginous choroiditis has multifocal confluent lesion which involves the posterior pole and the periphery as well. So with this in mind, we had a 16-year-old girl who presented to our OPD with progressive blurring of vision in the left eye for the last 6-7 months, and she also had associated pain and redness and occasional headache. There was no history of trauma or any other systemic illness associated. On examination, the right eye was normal, the anterior segment, whereas the left eye revealed a vision of 6/60, with the anterior segment showing granulomatous anterior uveitis kind of picture with mud and fat keratic precipitates, 2+ cells, and flare. And the pupillary reactions were sluggish as well. When we performed a dilated fundus examination, the right eye was normal, but the left eye showed multiple creamy colored lesions with a normal overlying retinal vessels indicative of an active multifocal kind of choroiditis picture. So with this, we started the patient on topical steroids, homatropin and moxifloxacin, and sent the uveitic profile for narrowing down the etiology. Of this, ESR was found to be raised, which was 55 millimeters, and MAN2 was positive with a redness of 16 millimeters and induration of 14 millimeters. With that, we had started the patient on oral steroids of 50 milligrams in the doses of 1 mg per kg OD dosing, and followed her up. So I'll be going through serial fundus photograph, right followed by the left. So at 1 month follow-up with on oral steroid, the right eye was again quiescent, it was the same, and the left eye was showing healing pattern. So we can see the lesions are more well demarcated now, it is acquiring pigmentation. The vision had also improved to 6/18, the KPs had resolved, and with that picture we started tapering the oral steroids. On the 2nd month follow-up, to our surprise, the right eye, which was the previously normal eye, developed a new lesion, that too parafoveally, and the vision in that eye had dropped as well to 6/18. And the left eye had shown another new lesion that had cropped up, juxtapapillary. So with that, we ordered HRCT thorax, which showed centrilobular emphysematous changes. So with a positive MAN2 and an HRCT thorax showing these kind of changes, we consulted a pulmonologist and started the patient on ATT and increased the dosage of oral steroid to 80 mg per day. So after this, the patient had shown a beautiful healing pattern over the course, and this is 3rd month follow-up. We can see the central, that parafoveal lesion that was located, it's more healed, becoming more demarcated, even the peripheral lesions also. And this was the left eye. The OCT was showing the similar picture with RP, atrophic changes in the RP. So I'll be just running through these follow-up slides. 5th month follow-up, all the lesions were very nicely scarring and showing, were requiring more pigmentation at the 7th month. At this point of time, the steroids had been slowly tapered and she was off steroids by March, and she was maintaining a vision of 6/6, best corrected a vision of 6/6 in both the eyes. And the patient is still on ATT at 7th month as well, 8th month, 9th month. And this is the annual follow-up, and this is the last follow-up that we can see multifocal choroiditis, all the patches that are healed. So serpiginous choroiditis can be of a classical form, which is essentially autoimmune, or it can be serpiginous-like, which is infective of tubercular origin, especially in our country. So it's very important to diagnose it appropriately so that we can initiate anti-tubercular treatment as soon as possible. Needless to say, a strict follow-up, counseling the patient regarding the treatment and sticking to the anti-tubercular treatment with proper documentation is an essential key, which can help us go from a picture like this to this.